Um, Welcome to the presidential plenary for the SSAT. The first talk is adjuvant chemotherapy in older patients with locally advanced colon cancer is less more. This is going to be presented by Julia Freibalt from the University of Minnesota Twin Cities in Minneapolis.
Good morning. My name is Julia Freibalt. I'm a general surgery resident at Hennepin Healthcare in Minneapolis, currently in my dedicated research years with the University of Minnesota. Thank you to the Society and the President for the opportunity to present this morning. Today I will be discussing our group's work regarding adjuvant chemotherapy in patients with locally advanced colon cancer. I have no disclosures. Locally advanced colon cancer encompasses stage 2 and 3 colon cancers, and in patients who are treated with surgery first, patients can move on to a surveillance-only approach or be treated with adjuvant chemotherapy with single-agent chemotherapy or multi-agent chemotherapy. Current NCCN guidelines recommend the use of adjuvant chemotherapy in cancers with high-risk features, but don't provide distinction based on patient-specific factors when choosing optimal regimens. However, there is an addition to the recommendations regarding the limited benefit of multi-agent chemotherapy in patients age 70 and over, as additional agents may increase morbidity in this higher risk population without substantial benefit in prognosis. Given this variation in guidelines, we sought to assess whether the survival benefit of single and multi-agent chemotherapy in patients with locally advanced colon cancer diminishes with age. We hypothesized that there was a subgroup of older patients who may not benefit from increased chemotherapy. To accomplish this, the National Cancer Database was queried for adults who underwent surgical resection for colon adenocarcinoma from 2010 to 2020. 3 groups were analyzed, the first with low-risk stage 2 disease, including patients with tumor stage 3, no lymphovascular or perineural invasion, and well or moderately differentiated grade. The second was those with high-risk stage 2 disease, patients with pathologic stage 2, and one of the following high-risk features: tumor stage 4, positive lymphovascular or perineural invasion, and poorly differentiated grade. And the third was patients with pathologic stage 3 disease. Patients who received neoadjuvant chemotherapy or other systemic therapy were excluded, and multivariable Cox regression models with an interaction term were used to estimate the differential effect of adjuvant chemotherapy on overall survival by age. In an overall cohort of over 60,000 patients, 30% had low-risk stage 2 disease, 17% high-risk stage 2, and over half with stage 3 disease. The majority of our patients were in the youngest but largest age group, and patients were most commonly male, white, and healthy with a Charlson-Dale score of 0, and these factors were balanced between stage groups. In both stage 2 groups, the majority of patients did not receive adjuvant chemotherapy, but a larger proportion of patients in the high-risk stage 2 group received single and multi-agent chemotherapy compared to low-risk stage 2. In stage 3, the majority received multi-agent chemotherapy, with just under 25% treated with surveillance alone. On a multivariable analysis of factors associated with the receipt of chemotherapy, in the low-risk stage 2 group, those with increased age and higher comorbidity score were less likely to receive adjuvant chemotherapy. Increased tumor size and distal tumors had a higher likelihood of receiving both single and multi-agent chemotherapy. In the high-risk stage 2 group, similarly, older and those with increased comorbidities were less likely to receive chemotherapy. Among other significant associations, higher stage tumors were more likely to receive chemotherapy, as well as those with positive lymphovascular and perineural invasion. In the stage 3 group, patients aged over 80 were half as likely to receive single agent and over 90% less likely to receive multi-agent chemotherapy. Those with higher comorbidity scores were also less likely to receive adjuvant chemotherapy, but we didn't see a strong association with pathologic T stage, but increased lymph node involvement was more likely to receive multi-agent chemotherapy, indicating that this decision was likely made based on lymph node status. Moving on to our survival analysis, for lower stage 2 disease, 10-year overall survival is 60%, so stratified into 57% with patients who did not receive any chemotherapy and a higher overall survival in those who received single and multi-agent chemotherapy. In our interaction term of the multivariable analysis, age did not impact the survival benefit of adjuvant chemotherapy, evidenced by similar hazard ratios for each group. Regardless of age, we didn't see a significant overall survival benefit to patients who received single or multi-agent chemotherapy compared to observation alone. This is a visual representation of those hazard ratios estimated at the most commonly represented variables. We see that predicted overall survival was similar for each chemotherapy type, but varied as age increased. In the high-risk stage 2 group, 10-year overall survival is 55%, stratified into 72% 10-year overall survival for both adjuvant chemotherapy groups, and 46% for those who did not receive chemotherapy. In our interaction term, hazard ratios again were similar for each chemotherapy group despite age, indicating that age did not impact the survival benefit of chemotherapy for high-risk stage 2 disease. We did see a survival benefit to single agent over multi-agent chemotherapy, evidenced by the lower hazard ratios in that group. And in our visual representation of these hazard ratios, we see that those who did not receive chemotherapy had a lower predicted overall survival in all age groups, but there was a benefit to single agent over multi-agent chemotherapy. In the stage 3 group, 10-year overall survival is 55%. Those who did not receive chemotherapy had a 22% 10-year overall survival, with increasing odds of survival as adjuvant chemotherapy increased. Again, in our interaction term, even in stage 3, similar hazard ratios indicate that age did not impact the survival effect of chemotherapy. We see a decreased risk of mortality in those who receive multi-agent chemotherapy. And this is again demonstrated in our graphical analysis with the top green line representing multi-agent chemotherapy and therefore an improved overall survival for these patients. In summary, in this analysis of over 60,000 patients with locally advanced colon cancer, while chemotherapy was most often withheld from older patients, age did not significantly impact the survival effect of adjuvant chemotherapy. In low-risk stage 2 cancer, there was no significant benefit to the addition of adjuvant chemotherapy, while there was benefit of single agent over multi-agent in high-risk stage 2 disease and multi-agent over single agent in stage 3 cancers. These findings are in line with current guidelines to selectively use adjuvant chemotherapy in patients at higher risk for recurrence. Patient and cancer-specific factors, including the presence of node positivity and other high-risk features, are important in choosing optimal adjuvant chemotherapy, but this decision should not be based on age alone. This population benefits from an individual decision-making approach based on functional status that balances oncologic outcomes with quality of life. Thank you. I'd be happy to take any questions.
Thank you for this very elegant study on and showing us that age is not really a factor in making this decision on adjuvant chemotherapy for locally advanced colon cancer. I'll start with one question. By the nature of the study, you've auto-selected the fit older patients, right? So does your regression analysis account for the fact that fewer patients in the older age group went on to receive chemotherapy? And intuitively, it probably was the people that were fit that took the chemotherapy. So do you think the two populations are really different?
Thank you for that question. I think you've pointed out a limitation of this study. We have a large selection bias, obviously, for the patients who did receive chemotherapy. We didn't do any sort of matching based on comorbidity status, but we did see that, like you pointed out, that patients who had lower comorbidities were more likely to receive the chemotherapy. So I think that does affect our results.
Still a great study, though. Thank you.
Thanks.
Also, how do you take this forward? So, how do you use this in your decision making? Especially, I'm interested in the stage 3 disease. How do you decide between multi-agent and single agent? How do you have these conversations with patients?
Yeah, I think there's studies that support an increased toxicity for multi-agent chemotherapy, especially in older patients. But I think our study shows that We should be balancing those things like frailty and comorbidity status when making that decision. So I think if you have a fit, independent 80-year-old that appears that they would tolerate multi-agent chemotherapy and would benefit from that, I think it's a good idea.
Did you also look at disease-specific survival? Because a lot of these people may not be dying of colon cancer.
Yeah, I think that's very important. Unfortunately, that's not a variable available in the National Cancer Database, but I think that's a good next direction for a different database or population.
Excellent. Any other questions? Thank you.
Thanks.
The next talk is entitled Exponential Surge in Anti-Reflux Surgery Utilization in the United States, Results from a 25-Year Nationwide Population-Based Analysis. This is going to be presented by Daniel Samadi Brada from the University, from Metro Health Medical Center, Case Western Reserve University in Cleveland.
Good morning, everyone. My name is Daniel Simadi Brada. I'm a internal medicine resident at Case Western Reserve University. First of all, thank you, moderators, and thank you, SSAT, for the opportunity to present this finding today. So I'll be presenting our research project, Exponential Surge in Anti-Reflux Surgery Utilization in the United States, Results from a Nationwide Population-Based Analysis. First, I have nothing to disclose. So gastroesophageal reflux disease, for short GERD, is a rising global concern. From 1990 to the year 2019, the prevalence and incidence of GERD increased by 77.5% and 74.8%. And now the global prevalence of GERD is around 14% and is much higher in the United States, which is roughly around 20%. Based on a large nationwide survey in the United States, roughly 30% reported having GERD symptoms in the past week. And among those taking daily PPIs, more than 50% had persistent GERD symptoms. So in terms of the management of GERD, typically it involves having lifestyle modifications and medical therapy. However, in those that has inadequate symptom relief from medical therapy or seeking alternatives to long-term pharmacotherapy, anti-reflux surgery can be considered. And historically, the Nissen or the complete fundoplication has been utilized to treat these patients. However, newer techniques such as the partial fundoplication, known as the Toupet and Dor amongst others, have been reported. And most recently in the year 2012, the FDA has approved a new anti-reflux surgery technique utilizing the magnetic sphincter augmentation, also known as the LINX procedure, where it bolster the lower esophageal sphincter with a magnetic device. Earlier reports showed an increase in the anti-reflux surgery utilization from 4.4 to 12.0 out of 100,000 adults. However, most recent data showed a decline in the surgical fundoplication utilization starting in the year 2009 to 2013. No other reports have investigated the utilization of anti-reflux surgery ever since, especially given the approval of the magnetic sphincter augmentation. So the aim of this study was to investigated temporal trends in the utilization of anti-reflux surgery in the United States from the year 1995 through 2024. We utilized the TriNetX database, which is an aggregated, de-identified electronic health records database from multiple healthcare organizations globally and is HIPAA compliant. We specifically used the United States Collaborative Network database, which housed data from 120 million individuals across 70 US healthcare organizations. We identified all GERD patients from 1995 to 2024 using ICD-10 codes, and that includes patients with erosive esophagitis, non-erosive reflux disease, and Barrett's esophagus. We calculated the annual incidence rates for surgical fundoplication and magnetic sphincter augmentation, and that is defined as the number of new cases per 100,000 GERD patients, and cases were identified using CPT codes. We employed a joint point regression analysis, which calculated the annual percentage change and the 95% confidence intervals, including the trend changes. We also did a subgroup analysis based on GERD phenotypes, age, sex, and body mass index. And statistical significance was set at a p less than 0.05. Here are the baseline characteristics of patients undergoing anti-reflux surgery. 62,000 patients underwent surgical fundoplication, while roughly 1,700 patients underwent magnetic sphincter augmentation. Generally, patients undergoing surgical fundoplication was relatively older than patients undergoing magnetic sphincter augmentation, and more female proportion underwent surgical fundoplication. In terms of this utilization of surgical fundoplication, we identified 4 distinct trends based on the joint point regression analysis. Initially, there was no significant change in the trends of anti-reflux of surgical fundoplication from 1995 to the year 1997, and this was followed by a significant increase of utilization until the year 2000, and subsequently followed by a significant decrease by an annual percentage change of 15% up to 2007, and it was followed by a continuous increase until 2024. In terms of magnetic sphincter augmentation, it was first reported in the database in the year 2016. It showed an initial uptake from the year 2016 to the year 2018, peaking at 7.08 new cases per 100,000 GERD patients in the year 2018. However, this was followed by a continuous decline ever since. And based on subgroup analysis, both anti-reflux surgery were primarily utilized in patients with erosive esophagitis and Barrett's esophagus. In terms of age, there was no difference in the utilization of both surgical fundoplication and magnetic sphincter augmentation. However, more younger patients under 65 years underwent magnetic sphincter augmentation. In terms of sex-based differences, more females underwent surgical fundoplication. However, more males underwent magnetic sphincter augmentation. In terms of BMI, both patients with BMI less than 35 underwent more frequent surgical fundoplication and magnetic sphincter augmentation compared to those with BMI greater than 35. So in summary, there was a resurgence in surgical fundoplication utilization following the year 2007, contradicting prior reports of a sustained decline in anti-reflux surgeries. Conversely, interest in the LINX procedure has significantly diminished in recent years after an initial rise. And both anti-reflux surgeries were primarily utilized in patients with erosive esophagitis and Barrett's esophagus. Thank you for listening to my presentation. I'm happy to take any questions.
Shahin Ayazi from Pittsburgh. Dr. Simodiwatra, congratulations on a timely and well-done study. I was pleasantly surprised to see a GI group shed light to the rise of anti-reflux surgery in US. So it feels like more like an olive branch from GI side, so we'll take it. But I have a couple of questions. First one about utilization of TriNetX data. So if TriNetX truly capture about 30% of US population, I was expecting higher number of LINX procedures. We know 40,000 LINX implant has been done in US so far, and you are reporting less than 2,000. This is also true for the number of anti-reflux surgeries, which is based on previous analysis. We expect somewhere around 500,000 in this time frame, and you are reporting about 160,000. How do you explain this discrepancy? Is it because of the coding situation? Is it because people don't submit their data to the TriNetX, or you have other explanation? Secondly, the decline in the links number really stands out. Do you think this is the result of evolving clinical practice and the outcome of links, or is it more because of the challenges we have with the reimbursement and authorization? And the last one, did you do any analysis based on the region or institution to see if these data is primarily dictated by some large volume centers or is more of a national trend? Well done. Thank you.
Thank you so much for the amazing questions. So in regards to question number one, in terms of the number of cases that are reported in the TriNetX database, I think there are many different possibilities that could potentially happen. As you mentioned, the database does not capture the whole United States data. And that's a possibility. Also a possibility with, because we identified these procedures based on CPT codes, there's also a possibility of miscoding as well. However, what we wanted to emphasize in this study is the incidence rates instead of the number of cases, so it accounts with the number of the population that is available in the TriNetX database.
But what is just focusing on 5% of population, draw a conclusion for national trends, it may be a little bit concerning. We have to be cautious about analysis. We participate in TriNetX data, and we have 800 links. So almost half of this only comes from us. So I'm sure the other institutions have done the same.
Yeah. And I think one of them is that we only identified our base population is GERD patients. Sometimes that also changes things up. Yeah, and in regards to the second question, I think that's a good point. Unfortunately, we're not able to know if, based on our analysis, if the decline in links procedure is based on reimbursement issues, but that may also contribute to that. However, I think also the lack of the data in terms of long-term outcomes of links procedure, they can also contribute to the decline in the interest. And in terms of the last question, unfortunately, we have not done an analysis based on the regions, but I think that's a good step for next step. Thank you.
Dr. Volanovic.
Thank you for this very nice study. My only disappointment is that the rates didn't go up faster. But my question has to do with, just to be clear, these were all first-time fundoplications? There weren't any, did you count any redos or secondary fundoplications or any revisional surgeries?
Yes, that's a great question. So this is the time, we only identified the index or the first
And my
procedure.
And my second question is, how did you handle hiatal hernia repairs without fundoplications? Because that's done not infrequently.
Yes, so we specifically included CPT codes that excludes those patients undergoing hiatal hernia procedures.
Any other questions from the floor? Thank you.
All right, thank you.
Thank you. The next talk is entitled Postoperative ctDNA is Associated with Outcomes After Curative Intent Hepatectomy, Results from the Intercept Program. This is going to be presented by Dr. Brittany Fields at the MD Anderson Cancer Center in Houston.
Good morning, everyone. Thank you for the opportunity to present at SSAT. So, curative intent hepatectomy for colorectal liver metastasis is an effective treatment option for patients with stage 4 disease. Excuse me. It can lead to up to 70% 5-year overall survival in select patients with a favorable mutational profile. But despite its initial effectiveness, more than 80% of patients will experience clinical recurrence. Circulating tumor DNA, or ctDNA, is a dynamic biomarker developed from tumor-informed assays that, when detected, indicates the presence of molecular recurrence. And after intended curative intent oncologic treatment when all macroscopic disease has been removed, the detection of ctDNA in the absence of radiographic evidence of disease is defined as minimal residual disease, or MRD. And while residual tumor may not be grossly evident, MRD status is associated with increased rates of recurrence and worse survival outcomes. So after implementing an institutional initiative for routine surveillance in colorectal cancer using plasma ctDNA, termed the INTERCEPT program, we sought to evaluate the feasibility of longitudinal ctDNA testing, as well as the significance of ctDNA detection after curative intent hepatectomy for colorectal liver metastasis over the first 18 months of the program. This is a simplified schematic of the ongoing INTERCEPT program, with the arrows indicating the time points at which ctDNA is assessed. And for the purpose of this study, we focused on the ctDNA results after hepatectomy in these patients. For initial development of the ctDNA assay used, whole blood samples from each patient, along with tumor and matched normal tissue, are sent to the lab, where whole genomic sequencing is then performed, yielding a tumor-informed assay. And this allows for detection of somatic and truncal variants in the circulating blood when subsequent testing is desired. And as only whole blood is required for each additional test, facilitates longitudinal surveillance. Using the electronic medical record and a prospectively maintained liver database, we identified adult patients who underwent specifically curative intent hepatectomy from the start of the program in December of 2021 through June of 2024, and who also had plasma ctDNA testing within 90 days of surgery. The last follow-up was assessed in September of 2024. As far as determining the feasibility of integrated ctDNA collection, 166 patients with colorectal liver metastasis underwent curative intent hepatectomy during the study period. 33 of those patients did not have a postoperative ctDNA result collected within 90 days. And this left a remaining 133, or 81% of the initial cohort, that had at least one postoperative ctDNA collected. The median time to ctDNA collection for these patients was 28 days, and the median number of tests was 3. Of these 133 patients, 75% had synchronous disease, a quarter had a primary tumor in the right colon, more than half had a left colon primary, and the remaining 16% had a rectal primary tumor. 87% underwent resection of their primary tumor first, compared to 13% who had a combined resection. The median number of hepatic metastases was 1, at a median size of 2.1 centimeters. And within 90 days of curative intent hepatectomy, 23% of patients had a detectable ctDNA. We then compared characteristics between the ctDNA positive and ctDNA negative patients. And among their pathologic factors, there was, perhaps unsurprisingly, a greater proportion of ctDNA positive patients who received adjuvant chemotherapy. There were also differences in the hepatic tumor burden between the two groups. Upon assessing more closely these differences, the ctDNA positive patients had 2 compared to 1 hepatic tumor resected, a median tumor size of 3 versus 2 centimeters, and also had 3 compared to 2 hepatic segments that were involved with disease. We then looked at the frequency of somatic mutations by ctDNA result, which demonstrated only a statistically significant difference in the frequency of NRAS mutations and no differences in mutations of other commonly associated genes. We created a regression model to assess for the factors that were associated with ctDNA detection within 90 days of curative intent hepatectomy. And the factors shown here were all significant in the univariable model. And when controlling for these, we saw a significant association identified between ctDNA positivity and having a rectal primary tumor, as well as having any hepatic tumor that was 3 centimeters in size or larger. As previously shown, the majority of patients, or 70% of the entire cohort, received adjuvant chemotherapy. And this included 87% of ctDNA positive patients who were treated over a median of 3.6 months. This resulted in 63% of patients with an available test experiencing ctDNA clearance. Additionally, 65% of the ctDNA negative patient cohort received adjuvant therapy, for whom the most common indication was to complete 12 total cycles of perioperative treatment. With this in mind, we then analyzed recurrence patterns, which demonstrated that more than half, or 54%, of all patients recurred during the study period. This included 90% of the ctDNA positive patients, who were twice as likely to experience any recurrence compared to their ctDNA negative counterparts. The rates of hepatic-specific recurrence were also more than 3 times greater for the ctDNA positive patients, and the recurrence-free survival intervals were starkly different as well. Looking specifically at the site-agnostic recurrence-free survival, a 3-month median survival was observed in ctDNA positive patients, shown in red, compared to 21 months in the ctDNA negative patient group. Hepatic-specific disease-free survival was also much worse in ctDNA positive patients, at a median of 4 months, while it was not reached in the ctDNA negative patient group. In summary, rectal primaries and larger hepatic tumors are associated with higher risk of molecular recurrence, or MRD, and this risk may be further increased by the presence of an NRAS mutation. Furthermore, in the setting of a positive ctDNA, clearance achieved with adjuvant therapy does not prevent disease recurrence. In our experience, longitudinal surveillance using ctDNA testing after curative intent hepatectomy for colorectal liver metastasis is beneficial and can be feasibly integrated into clinical practice. It allows us to stratify patients into high and low risk for recurrence, and therefore may be used to guide postoperative chemotherapy de-escalation as well as surveillance intensity. It also indicates the urgent need for novel therapeutic strategies for patients with MRD or otherwise high-risk patients. Ongoing development of even more sensitive and specific assays, however, may further improve performance. Thank you, and I welcome any questions.
Hi, I'm Yoshi Kawaguchi from the University of Tokyo. It is an honor to be a discussant for your outstanding study. I appreciate that you include my research in your slide, and as a former fellow of Dr. Bote, we share the same academic lineage. Congratulations, Dr. Field. So ctDNA is emerging as a promising marker for minimal residual disease. Evaluating its postoperative dynamic changes could significantly influence clinical decision-making after surgery, given that ctDNA positivity is a highly sensitive indicator for early recurrence. Moving forward, the impact of ctDNA clearance on prognosis may be an important research question. I'm particularly interested in how postoperative ctDNA status can be integrated into future clinical practice. I have 2 questions regarding your excellent presentation. Number 1, how do you incorporate ctDNA positivity or negativity into refining post-hepatectomy management strategies? Could you provide a stratification of patients based on post-operative ctDNA positive and ctDNA negative status? Number 2, does ctDNA status depend on the timing of adjuvant chemotherapy initiation after surgery? Specifically, if patients who begin adjuvant chemo earlier show higher rate of ctDNA clearance, that would be a valuable clinical implication. Again, thank you very much for being a discussant for your presentation.
Thank you very much, Dr. Kawaguchi, for those excellent questions. So to your first question, as far as refining how we do postoperative management of these patients, I think it presents 2 different opportunities in the care of these patients. The first being to utilize more risk-stratified treatment strategies. So in the ctDNA positive patients, we know that they're already higher risk for recurrence. So once we've identified these patients postoperatively, and eventually in the preoperative period as well, we can intervene sooner and make more informed decisions as far as how we're going to manage them, whether that's with our standard systemic therapy, with escalation of treatment, or even with novel therapies using MRD biomarker integrated clinical trials. And then in select patients, when appropriate, we can consider regional treatments as well. The second opportunity to use ctDNA status is to determine the timing of surveillance, as well as to create a more personalized approach based off of the predicted time to recurrence. So I didn't have time to show the data here, but the median time to MRD for the ctDNA negative patients was actually 5.2 months, but our current surveillance strategies calls for imaging around that 3 to 4 postoperative period. 3 to 4 month post-operative period. So we can potentially lengthen that time in the lower risk patients and also provide not only a treatment break, but an imaging break to these patients, while knowing that we still have a window of opportunity to intervene when necessary. And then as far as the second question about whether or not the ctDNA status depended on timing, because it's our practice to see patients within 1 month of surgery and the median time to obtain that first test is 28 days, we usually already have a plan for adjuvant chemotherapy and we know the results by that time. So I don't think we can say that the adjuvant chemo is actually influencing the ctDNA results in these patients, but we have observed, at least anecdotally, the opposite relationship happening. And so the ctDNA positive group is more commonly being treated adjuvantly with doublet chemotherapy, whereas our ctDNA negative patients, even though they are ctDNA negative, are still receiving chemotherapy, but it's more likely maintenance or monotherapy in those patients.
Congratulations.
Thank you.
Excellent study. My question is, and you may have presented this, and I may have missed it. If I do, I apologize. But do you check the ctDNA preoperatively?
We do,
Okay,
but
and do you have data on the conversion of CT positive patients to CT negative pre-op to post-op, or CT negative patients converted to CT positive patients pre-op and post-op, and does that make a difference?
yes, thank you for that question. We do have that data. We have not analyzed that in the context of this study, but those ongoing analyses are being done at this time.
All right, thank you.
It's an interesting question, because in the group that's ctDNA positive, the median survivals or recurrence-free survival is really, really short. So, if there's a way to predict which patient's ctDNA is going to respond, it may even help us decide when we operate on the colorectal liver mets. Dr. Walsh.
Matt Walsh from Cleveland. 2 quick questions, and I may have missed it. Does it correlate with CEA level at all? And secondarily, does the ctDNA positive group beg for more intra-arterial infusion pump treatment of those that are positive?
Thank you for those questions, Dr. Walsh. So as far as whether or not it correlates with CEA, we have a previous study published in 2020 in Annals of Surgery where we actually looked at the ctDNA status in CEA, and we found that they did not correlate. So for the purpose of this study, we didn't compare it to the CEA trends in this patient population. And then for the second question regarding the ctDNA positive begging for HAI therapy, I think that is an important consideration. We don't currently use that, but that is something that may be beneficial in this specific patient population, where we've already proven that our conventional and systemic chemotherapies are not as effective.
Findings in rectal cancer are interesting. I know it's a small N probably in the rectal cancer. Do they all get neoadjuvant chemoradiation, total neoadjuvant therapy? Because they seem more likely to be ctDNA positive. Why do you think that is?
Right. So as we know, as you mentioned, the rectal cancer patients are already higher risk. And so more than 80% of all of our patients receive neoadjuvant therapy, specifically looking at chemoradiation in that cohort. The majority of them, over 90% of them, did receive chemoradiation. It is currently our practice to utilize a liver-first approach in the rectal primary patients because they are more aggressive. And so the N is so small because we assume that these patients who qualify for this study are potentially have less aggressive disease, but that's something that warrants further investigation.
Excellent. Thank you very much.
Thank you.
Thank you. The next talk is entitled Specific Targeting of Pancreatic Cancer in Orthotopic Mouse Models with an Anti-CA19-9 Antibody Conjugated to a Neurofluorophore. This is going to be presented by Dr. Javier Bravo. I'm from the University of California, San Diego.
Thank you for the introduction, and thank you to the SAT for the opportunity to present. No disclosures. Quick overview of the presentation today. We'll do some background on PDAC. We'll talk about a prior work in fluorescence labeling of tumors. We will discuss the pancreatic cancer cell lines and the model creation in this study, as well as the imaging systems and techniques that we used. And we'll talk about the future direction and conclusions. So pancreatic ductal adenocarcinoma is the third leading cause of cancer-related deaths worldwide, with a 5-year survival rate of 13%. Locally advanced and metastatic disease is found in around 80% of patients, and serum CA19-9 is elevated in 80% of patients. R0 resection is crucial to improve outcomes and survivability, and this is the rationale behind the study. Since CA19-9 is so prevalent in PDAC cases and surgery, surgery is crucial for survivability. So developing techniques for improved detection of primary tumors and metastasis is imperative. Previous clinical trials using fluorescent antibodies in pancreatic cancer include this trial from 2018 using Sturgemab, which targets CEA. It was used intraoperatively using spy fluorescence, and primary and metastatic tumors were identified. The tumor to background ratios are 1.6 and 1.7. Another clinical trial, 2020, used an anti-EGFR agent, which was conjugated to a fluorescent dye. This was panitumumab, and they were able to detect peritoneal metastases with higher tumor to background ratios. And another anti-EGFR molecule, cetuximab, conjugated to IR-800, was able to detect lymph nodes smaller than 5 millimeters with an 88% sensitivity. This study basically showcases the sensitivity that fluorescent dyes have the potential to achieve. And other preclinical studies use other anti-CEA nanobodies and other molecules in pancreatic cancer like MUC4 with promising results. In our study, we used anti-CA19-9 antibody. These are the characteristics of the antibody. Since it targets CA19-9, it's an excellent molecule for PDAC. The antibody is conjugated to the fluorescent dye IR dye 800. This dye has an emission and absorbance peaks similar to ICG, which makes it an excellent clinical tool, since most of the cameras that pick up ICG are also able to pick up IR dye 800. For our subcutaneous model creation, we used SW1990 and MIAPACA2 cell lines. These are both human pancreatic cell lines. SW1990 is positive for CA19-9 expression, and MIAPACA2 is negative. We used it as a control. Mice were anesthetized, and small tumor fragments were injected in the subcutaneous flanks of mice. Tumors then grew to around 1 centimeter before we injected the antibody dye conjugate. And these are our models, 72 hours after the injection of the antibody dye conjugate. In this image, we have the mouse with 2 tumors. The tumor with the yellow arrow is pointing to the MIAPACA2 tumor, and the white arrow is signaling the SW1990 tumor. Again, this is the positive CA19-9 tumor. So panel B is the near-infrared light image, which shows that the antibody dye conjugate brightly targets the SW90 tumor in the right flank in comparison to the MIAPACA tumor, which does not express CA19-9. And in panel C, we have the tumor to background ratios, which were significantly higher in the SW1990 cell line compared to MIAPACA. We also created orthotopic mouse models, and for these models we used SW1990 and BXPC3, which are both human pancreatic cell lines and both positive for CA19-9 expression. We anesthetized the mice and implanted small tumor fragments of either cell line into the pancreas of mice and allowed the tumors to grow for 3 weeks. After tumor growth, we injected either CA19-9 IR-800 or IgG IR-800 as a control, which has nonspecific targeting. We use the Pearl small animal imaging system for near-infrared imaging in our lab, and this is what it looks like. It allows for high-quality images in controlled environments, so it's great for preclinical studies. And these are the bright light and near-infrared images of the orthotopic models using SW1990. The white arrows, again, are pointing to the tumor, and the yellow arrows are pointing to normal pancreas. In panels A and A prime on the left show the tumor labeled with the anti-CA19-9 antibody, and panel B shows the IgG demonstrating the non-specific labeling. And again, the antibody-drug conjugate brightly targeted the tumor cells for this cell line. Again, the tumor to pancreas ratios on the right are very promising. In this study, to simulate a clinical trial scenario, we also used the Stryker 1688 laparoscope, which is clinically available and widely used. And these are our laparoscopic images using SPI fluorescence. This is the same mouse as the previous slide, and with the SW1990 tumor cells after injection of the antibody-drug conjugate. So on panel A at the top, we have the CA19-9 targeting with SPI fluorescence, and in the panel B at the bottom, we have the IgG control, which again shows non-specific labeling. We can see that the SPI fluorescence was able to identify the tumors, and also the TPRs and TLRs were significantly higher to the IgG control. And our other cell line, BXPC3, also demonstrated good binding of the antibody to the tumor cells. Panels A on the left, again, is the CA19-9 IR800 conjugate, and the panel B on the right is the IgG nonspecific targeting. We had very promising tumor to pancreas ratios as well. This is a biodistribution analysis, which allows us to find the area of highest mean fluorescence intensity. So the mice injected with CA19-9 clearly demonstrated the highest mean fluorescence intensity in the tumors, and the IgG IR800 mice injected with IgG IR800 demonstrated the highest mean fluorescence intensity in the liver. And we had similar results for the other cell line with the same antibody-drug conjugate, where the tumor had the highest mean fluorescence intensity compared to IgG, which was highest in the liver. We also have H&E staining of the pancreatic cancer on the left for both cell lines, and we confirmed that it was poorly differentiated pancreatic cancer. And to the right, the middle image, we have a CA19-9 staining of both cell lines, and we were able to confirm the expression of the molecule with more prominent staining on SW1990, suggesting it may have a higher expression profile. And tumors treated with the isotope control IgG on the image all the way to the right showed no specific staining. So we were able to demonstrate that CA19-9 IR800 brightly and specifically labels mouse models of pancreatic cancers. We achieved very high TPRs, and we also achieved high TPRs using SPI fluorescence, which is comparable to clinical trials. And this is just a study proof of concept that tumor-specific fluorescent antibodies are clinically promising tools for improving oncologic resection and overall survivability. Future direction, we have metastatic model and lymph node analysis studies, and we also are planning to use SPI fluorescence and clinically available laparoscopes more often to accelerate clinical translation. And another interesting point is the margin analysis to see if the actual laparoscopic fluorescent border corresponds with the pathologic border. And depth of penetration studies would also help accelerate clinical translation. Thank you for your time, and I'm happy to take any questions.
Thank you.
Hi, Young Hong
Dr.
from
Hong.
Cooper University in Camden, New Jersey. I want to thank you and the authors on a fabulous work. I really enjoyed reading your manuscript, and congratulate you guys on the great work you've done. So I have a couple exciting questions, really, because I'm excited about how this is an implication for future oncologic surgery. And when I think about that, you kind of mentioned in future directions, like what are your sensitivities for isolated lymph nodes and the pickup of that, the depth of the liver metastasis? Can you see that operatively? In the mouse model, when you cut into the mouse, how deep does the fluorescence penetrate? So if the tumor was really within the pancreas, a small lesion, could you really see that? And I think you kind of alluded that for future direction. The second question is, when I think about immunofluorescence, it's more like, I may be oversimplifying it, but when you're isolating protein in the lab, you do a Western, you do a blocking procedure to really minimize the off background pickup. So is there any ways to block the false negative or false positive readings in the liver and the surrounding tissue? And really, I think the goal is to get a better oncologic resection, but I think, those of us that do a lot of pancreas surgery, know that despite your best efforts, the tumors come back. And so when you think about imaging, about targets using antibody, I start to think about dotatate imaging and how that's really specific. And then from that, Lutathera therapy came out. So is there a way that you can target using CA19-9 antibody to tag a therapeutic agent like instead of fluorescence in the future? And if that's the case, what is the contraindication for possibly using cellular therapy like CAR T as a possibility as a target using antibodies? Thank you.
Yeah. Thank you, Dr. Hahn, for your questions. Three very good questions. To answer your first one, we are currently actually developing a model for detecting liver metastasis in pancreatic cancer, where we implant tumor fragments at different depths in the liver, and we were planning to inject the antibody to the same antibody dye conjugate to see what the sensitivity and the actual, power of detection that this antibody has. We also have a planned experiments for lymph nodes to test the sensitivity. In regards to the depth of penetration and the ability to detect tumors, the clinical trials, there's a couple of clinical trials that I mentioned. There's others out there that have shown pretty promising results about, being able to detect tumor in vivo and in human patients. So, we obviously would need to try to determine what the actual depth of penetration would be for this specific antibody dye conjugate, but we have kind of like a mainframe we can follow. And as far as the sensitivity, we also developed a peritoneal metastasis and peritoneal carcinomatosis model in which we were able to detect small implants as small as 1 to 2 millimeters. So we have a good study to kind of base future studies on, and hopefully again accelerate clinical translation. And one of the main reasons would be to allow for more precise tumor resection, but also diagnostic laparoscopy. If we're able to detect just a small tumor implant or a lymph node, then we can also help with decision making, pre-op. And as far as your question regarding the CAR T and diagnostic potential, we haven't tried that yet with this antibody, but that's a very it's a great question, because we should be feasible. There shouldn't be an issue to attach like a radioisotope to the molecule and test it. We haven't developed that yet, and it would be a great tool for theranostics in the future. I hope I answered all your questions.
Humans make CA19-9 at baseline, so, and mice don't. So do you think that would affect, our ability to see it in a human who has some baseline level of CA19-9?
Yeah, thank you. Great question. CA19-9 is definitely, that's something we or kind of predict, is that this can also target, normal CA19-9 expression. So what we do to adjust for that is the timing studies. We wait around 72 hours to 96 hours to allow for most of the antibody that was injected to go through washout and be excreted, while only the bound dye is there. And we also have a study using a pegylated antibody, in which this kind of changes the biodistribution of the antibody in vivo and allows for more specific targeting.
And, I think, one problem we have, even we're doing it open or laparoscopic, we feel a tumor or see a tumor, we resect it, and then there'll be microscopic positive cancer at the margin. We send frozen sections. Sometimes they tell me they're negative. Sometimes they come back positive. Like how small, like if they're able to look at that margin, would we be able to see microscopic tumor at that margin? I'm trying to think of best applications down the road. That, or, I can think in the patient who now has an elevated high CA19-9 to start, I'm like, maybe they have metastatic disease. We can't see anything. We just give them chemo. We see how it responds. Do we do a diagnostic laparoscopy with something like this to pick it up? What are the best clinical indications?
Yeah, excellent points. And yeah, I think, being able to detect, again, small tumors or metastases or lymph nodes would be the main, benefit of using this antibody to, stratify patients. If you have a small finding, then you don't take them to the operating room. And as far as the your initial point,
Microscopic margins.
yeah, the microscopic margin. So that's definitely an area in which we have some studies to look at and see how reliable our eyes are with the fluorescence in regards to the pathology.
Thank you.
Thank you.
Excellent. The next talk is entitled Cracking the Code, Key Factors Influencing Recurrence Timing After Hiatal Hernia Repair, to be presented by Mikhail Attar at Washington University in St. Louis.
Good morning. Thank you to the SSAT for allowing me to present our work. The title of our presentation is Key Factors Influencing Recurrence Timing After Hiatal Hernia Repair. These are our disclosures. They're not relevant to this presentation. A hiatal hernia is defined as any protrusion of an abdominal structure other than the esophagus through the diaphragm into the mediastinum, and that's most commonly the stomach. Minimally invasive transabdominal surgical repair is now considered the treatment of choice for symptomatic hiatal hernias. However, symptomatic recurrence following hiatal hernia repair is a significant clinical challenge, with rates of recurrence ranging from 15 to 50%, and many of these differences based on whether we consider it a radiographic recurrence or a symptomatic recurrence. Research to date has focused primarily on rates of recurrence, as I mentioned in the previous point, and few studies have investigated timing of recurrence and their causative factors. Therefore, in this study, we aim to investigate both patient-specific and technical factors influencing the timing of recurrence after hiatal hernia repair. To do this, we did a retrospective review of a prospectively maintained database of patients who were referred for revisional hiatal hernia repair between 2009 and 2024. These are patients that had had a previous hiatal hernia repair, either at our institution, but more commonly at another institution. And we also included patients that had multiple prior repairs as well. These patients electively presented with a symptomatic recurrence to our clinic, and we confirmed that they did have a recurrence via imaging obtained at our center, or if the images were available from the outside hospital. We then stratified the time between their index operation and recurrence as confirmed via imaging. These were stratified into very early, which we define as less than 3 months, early, which is between 3 and 12 months, medium-term recurrence between 12 and 36 months, and then late recurrence, which was more than 3 years after their initial repair. We looked at patient factors, the most important of which were listed here, including demographics, body mass index, the patient's smoking status, their clinical comorbidities, the number of repairs they previously had, as well as their preoperative symptoms, both their chief presentation symptom as well as their GERD HRQL scores. And then we also looked at procedural factors from their index repair, and this was taken from the operative note. And so all these patients that we analyzed did have operative notes available from their index operation or their most recent operation. And we looked at hospital volume. We looked at the urgency of that index operation, whether it was elective or urgent. We looked at the technique for the cheiroplasty that was performed, we looked at as to whether mesh was used and whether it was fixed in any certain way. We looked at whether a fundoplication was performed, and if it was performed, what type. And then we also looked at different pexying, both hiatal pexy, if it was performed, and whether or not abdominal pexy or gastropexy was performed. We compared groups using ANOVA and chi-square tests, and then we also performed a multivariable logistic regression, and our significance was defined as a p-value of less than 0.05. So to jump into our results, we identified about 800 patients that presented with a recurrence to our institution, and 661 of those patients had operative records that were sufficient for us to complete our analysis. So looking at patient demographics here and patient factors, we found that both age and sex was not associated with the timing of recurrence. We did find that a weight gain of more than 30 pounds after their initial operation, if they were an active smoker, or if they had a diagnosis of COPD, were all associated with very early or early recurrence more commonly. The number of times they had prior operations was not significantly associated with recurrence, and neither was their ASA score or their GERD HRQL scores. Additionally, we found that vomiting, if patient reported episodes of either vomiting or retching after their initial operation, this was associated with more early recurrences. Moving on to technical factors, we did find that in hospitals that performed less than 10 operations, anti-reflux operations per year, had more common very early and early recurrences. We did not find that mesh use had any bearing on timing of recurrence. We found that barbed suture use or endostitch use was associated with more early recurrences. In terms of fundoplication type, we found that if they did not perform a fundoplication, or if a door fundoplication was performed, it was more commonly associated with early recurrences. And then finally, on the other hand, in terms of hiatal pexy, if this was performed, this was more commonly associated with either a medium or late-term recurrence. Moving on to the multivariable regression analysis, this confirmed, after we controlled for various factors, our previous ANOVA and chi-square results. These were the factors that we found that were significantly associated with early or very early recurrence. Active smoking, weight gain more than 30 pounds, diagnosis of COPD, episodes of vomiting, hospitals that had low case volumes, performance of no fundoplication or a door fundoplication, and lack of hiatal pexy stitches. We also performed a multivariable analysis of very early recurrence only, and we did find that use of barbed suture or the endostitch was associated with very early recurrence. Our findings suggest that the timing of hiatal hernia recurrence is influenced by a combination of both patient-specific as well as procedural factors. Patients who are active smokers, who gain a significant amount of weight after their initial repair, or who report post-operative vomiting are more likely to have earlier recurrences. We also found that low hospital volume and lack of fundoplication lead to earlier recurrences. Looking at recurrences specifically in the first 3 months after index repair, we found that patients that underwent repair with barbed suture or endostitch device crural closures had those recurrences. Interestingly, obese patients or an absolute BMI at the time of operation did not have earlier recurrences, and also, interestingly, mesh use did not impact timing of recurrence. There are a number of limitations to our study, which would be that it was a retrospective review. It's a single center experience, a high volume center experience. And one thing to note is that since we defined recurrence as time between the index operation and imaging, some patients may have been miscategorized if they waited a long amount of time between when they had symptoms and when the imaging was actually performed. So in conclusion, we find that there are modifiable patient factors such as smoking, weight gain, and vomiting that should be addressed prior to a hiatal hernia repair or a redo repair. We found that high quality crural closure as well as a fundoplication is important and plays a key role in promoting the integrity of the hiatal hernia repair. We hope that these findings may provide guidance to surgeons who perform hiatal hernia repairs and may help optimize patient outcomes. Thank you. Happy to take any questions.
Thank you.
Matt Crow from Cleveland. You gave a very provocative title, Cracking the Code. I'm not quite sure you've done that, but nonetheless, you've presented new data that I think is very helpful for us to look at, and a complex physiology that manages not just the motility and interaction of the esophagogastric junction, but obstructive symptoms and mechanical problems of hiatal hernia repair. And this specifically is an important contribution because it reframes recurrences as a time-dependent failure mode as opposed to a binary endpoint. And I think that that is novel, and we appreciate that. You've leveraged a large single-center redo cohort, and your team identifies modifiable patient factors, smoking, weight regain, and retching, and several technical levers together that explain nearly half of your very early failures, which is unique in the literature. And translating those into preoperative counseling and potentially contributing to intraoperative checklists could meaningfully improve the way that we do paraesophageal hernia repairs. Of course, there are limitations, which you pointed out. It's a single-center retrospective study with inherent biases associated with such constructs. And we didn't have any great data on the indications for primary surgery, whether this is for GERD from a physiologic standpoint or from mechanical symptoms of paraesophageal hernia. And this could, of course, impact recurrence too. And hospital volume was reported, but not surgeon-specific experience, which may be a stronger surrogate for technique, and therefore recurrence were not modeled. I have two questions. The second one with two parts. So first of all, how were you able to get institutional volumes outside of your own? Was this a database or registry? I can't imagine it was actually in the operative notes, but I'm curious nonetheless. And then based on these findings and factors, how have you changed your own primary practice in regards to counseling about modifiable risk factors before surgery? And have you changed your own approach to revisional surgery based on these findings, including suture selection and closure technique, which is quite novel, use of fundoplication or resectional procedures such as conversion to Roux-en-Y for obesity or dysmotility? Thank you.
Thank you, Dr. Crow, for those great questions. To address your first question, there is a database. It's the American Hospital Association database, and many hospitals in the Midwest report their volumes to that database, and so we were able to look at that database, and you can mine it through CPT codes or procedure codes. And so, as you pointed out, it's not a surgeon-specific. It is hospital volume, but since it was 10 or less for the hospital, even if they had one surgeon, he or she is performing less than 10 per year. And then in terms of your second question, absolutely, we obviously see a lot more primary, either paraesophageal hernias or primary GERD patients. And so we aggressively counsel them about smoking cessation. And actually, our practice is not to perform a hiatal hernia repair in a patient who's actively smoking, because we believe that the first time of the repair is the best time to fix it in an appropriate manner so they don't have a redo. And then post-operatively, we very aggressively control the patient's nausea. They, in the hospital, they are on scheduled Zofran. And then really for the rest of their life, we're counseling them that they should aggressively control their nausea if they have any, GI bug or something like that. And we do give them prescription for Zofran, and we try to see these patients every year, and we'll refill their prescription if needed. In terms of your second part of your question, in terms of technical factors, we do routinely perform fundoplication, a tooth-paste fundoplication with our hiatal hernia repairs. And additionally, we do not use barbed suture or endostitch. Obviously this analysis was after the fact, but it was good that we don't use it. But I think that there's a lot of, I think in the technical realm, there's a lot of variability with surgeon to surgeon. So it's hard to say that you shouldn't use it just based on this study.
Thank you.
A very interesting paper. I think that, and I think these are really important questions. The thing that's fascinating to me is that, in the early days of laparoscopic fundoplication, Nissen, et cetera, we really did a lot of this early stuff at UCSF. We all use the endostitch. There's like thousands and thousands and thousands of publications. I mean, if you added the number, it'd be a big number of experts using it very successfully. I mean, I can't speak to the barb, that might be something else. But I really think if I remember your numbers on your table, that you had like 898, but your numbers in the endostitches and the barb were like really small, 2-digit, like 21. I mean, I think that before you make that kind of a comment, do you not think it would be reasonable to look at your own experience and maybe pick another colleague who's used these things successfully and see whether you throw the same data over your data, whether you get the same result? Because I think this kind of a comment is a little bit dangerous, and there are tricks. There certainly are tricks to using these instruments in this location, and you have to be experienced to know the tricks. But I think just to blame the suture or the device is a little tricky. What do you think about that?
Yeah, I think you're absolutely right. In terms of the endostitch specifically, there's a lot of variability in how you can use it. You know, there's different suture types available for the endostitch. So I think a future direction for us is to look into more details regarding that. And I think that in terms of surgeons who routinely use it and are very facile with it, they it might not be a problem for that. In terms of the barb suture use, as you can see here, the numbers are low compared to the other ones. And so really in this study, we're only seeing the recurrences and we're not looking at the greater N. So, there might be thousands of repairs done with barb suture, and here we have 21 and 17, which would be an absolute low number. But here we're only seeing the patients that did recur.
I think it may also be a surrogate for surgeon experience. You don't have like a surgeon volume in here, so definitely something to think about. Thank you.
Thank you.
Hey, Dr. Ryle, can I make a quick announcement? Just want to announce that just to everyone, just remember presidential address is at 10 o'clock in room 10 over on the other side. So thank you. I apologize.
Excellent. The last talk of the session is entitled Cardiovascular Risk Reduction in a Large Cohort Study, Comparative Outcomes of Sleeve Gastrectomy, Roux-en-Y Gastric Bypass, and Biliopancreatic Diversion Surgeries, to be presented by Wissam Ghussan from Boston University. I think you're good there. Yeah.
Good morning, everyone. My name is Wissam Ghussan. I'm a Boston University resident and a research collaborator at Mayo Clinic. Before starting, I would like to thank the SSAT committee for the opportunity to present our work here at DDW. The title of my talk is about cardiovascular risk reduction in a large cohort study, comparative outcomes of sleeve gastrectomy, Roux-en-Y gastric bypass, and biliopancreatic diversion surgeries. Before starting, I have no conflicts of interest. So as you all know, obesity is a chronic and a multifactorial disease that is associated with multiple cardiovascular comorbidities. And in fact, obesity is a major contributor to atherosclerotic cardiovascular disease. And this occurs by increasing systemic inflammation and also accelerating atherogenesis, and thereby it predisposes individuals to cardiovascular diseases. So it's very important for us to cure obesity and try to treat obesity. And one of the most effective treatment for this disease is metabolic and bariatric procedures. And this includes sleeve gastrectomy, Roux-en-Y gastric bypass, and biliopancreatic diversion surgeries. And these surgeries have been consistently to demonstrate a superiority compared to other interventions, including lifestyle and pharmacological interventions. However, although we know that the metabolic benefits of these surgeries, there remains a significant gap in which we don't have a real-world comparative analysis between all these three surgeries. For this reason, we performed this study and we hypothesized that the ASCVD improvement in duodenal switch is higher than Roux-en-Y gastric bypass and higher than sleeve gastrectomy. So our aims and our primary aim was to check for the change in the ASCVD 10-year and lifetime score. And then we wanted to further assess that. And we did that through assessing the total body weight loss, the change in lipid panel components, and also the change in blood pressure. So we performed a retrospective cohort study in which we included patients who underwent sleeve gastrectomy, Roux-en-Y, and duodenal switch. And we included all patients who underwent these surgeries and had at least 1 year of follow-up. And we excluded patients that had revisional surgeries within the study period and those that had systemic conditions affecting weight loss. So as you can see here, this is our demographic table. We had 607 patients compared between sleeve gastrectomy, Roux-en-Y, and duodenal switch. And there, as you can see, that there's no differences in terms of the demographic baseline data, including age, sex, and race. And in terms of other clinical parameters, as you can notice, the BMI for the duodenal switch was higher compared to the other surgeries. And in addition, the lifetime ASCVD score was lower in patients who underwent Roux-en-Y. As for the other comorbidities, hypertension and hyperlipidemia specifically, they were higher in patients with sleeve gastrectomy. As for obstructive sleep apnea, it was higher in duodenal switch. So here we come to our results. As you can see, and as expected, the ASCVD score improved superiorly in patients who underwent duodenal switch. And here we can see the lifetime score and also the 10-year score. In terms of lifetime, so the improvement was 9.9 for the duodenal switch, not much different with the Roux-en-Y, was 9.6, and it was only 3.5 for sleeve gastrectomy. As for the 10-year score, it improved 1.6% for the duodenal switch, 1% for the Roux-en-Y, and it worsened by 0.3% for sleeve gastrectomy. And then furthermore, we also assessed the weight loss outcomes. And as you can see here, duodenal switch did better in terms of weight loss. It was around 38% compared to 30% in Roux-en-Y and 20.9% for sleeve gastrectomy. And then we also assessed the blood pressure changes. There was an improvement by 10 points for sleeve gastrectomy, for the systolic blood pressure, and by 5 points for the diastolic in comparison to the other surgeries. And as for the cardiometabolic outcomes, also we always saw a significant improvement in terms of cholesterol and LDL levels in patients who underwent duodenal switch. And in terms of HDL, although it's statistically significant, however, clinically, it's not really significant, the change between 7 and 10 points. And then in order to see if actually the surgery improved these outcomes or it was something else or a confounding factor, we did a multivariate regression in which we assessed for any covariate or any confounders that were contributing to this improvement. And as you can see here, total body weight loss was the only significant factor that predicted the improvement in ASCVD score. The procedure type was not significant in this analysis, and this was done for the 10-year ASCVD score. And we also did it for the lifetime ASCVD improvement. And as you can see here, total body weight loss was also significant. However, procedure type was not. Finally, in terms of limitations, our study included mainly white patients, which limits the generalizability of our results. And this is an observational study, so there is always increased susceptibility to coding errors and missing data. And finally, this is a short-term follow-up. We only had 1 year of follow-up, so further studies are needed in order to assess longer follow-up periods. So in conclusion, we did demonstrate in this study that all 3 surgeries had significant improvement in the ASCVD score in terms of the score itself, weight loss, blood pressure, and lipid profiles. And we did show that the results with the duodenal switch were better compared to Roux-en-Y and sleeve gastrectomy. And in fact, total body weight loss was the only parameter that seemed to be significant in this study. And lastly, this is very important because a tailored approach is needed in order to prioritize the durable weight loss reduction in these surgeries. Finally, I would like to thank my mentors, Dr. Andres Acosta and Omar Ghanem, for the opportunity to present this work, and I'm open to any questions. Thank you.
Dr. Bordero.
Sergio Bardaro from Cleveland. So first of all, thank you to the SSIT leadership for allowing me to discuss this paper. Second, congratulations, Dr. Gussam, for another excellent study. I have been discussing your other presentation in the same conference, so believe it or not, I'm not after you. So once again, I will congratulate you for this excellent presentation and also for revitalizing the importance of a very important procedure like the BPDDS. As we discussed before, is probably one of the most effective procedures when in terms not only on metabolic effect, but also on total body weight loss that is in direct relationship with improvement of comorbidities. As you mentioned before, in addition to the limitation of a retrospective studies, you have a very particular population with 91% whites, although 74 females, that is very, very similar to the general bariatric population. I have some questions for you. The score that you determined on this study pertaining to the American College of Cardiology and the American Heart Association was meant to be done in every single visit. So as you may see here, you have some results, but in my opinion, it will be important that we revisit this result with further follow-up, as this with time may decrease, particularly in these particular patients where the effect of surgery is way beyond 1 year, not because of the weight loss, but also because the metabolic rearrangement. So what is your plan? I would like to know for that. The other thing is, when you see a patient in Mayo Clinic or Boston University from now on, are you going to follow the BMI criteria that is generally used to determine what type of procedure you are going to perform? Or you are going to await that decision by using the cardiovascular risk, providing that this is ultimately your goal for these patients? And last, I know it's a retrospective study, but knowing the metabolic association with inflammatory effect of obesity on these patients, eventually this can open for you the door to check other inflammatory marker modification during the process. Last, on the effect of these changes in your risk, also the social determinants of health may have an impact, especially with your particular population. Thank you so much once again.
Yeah, of course. Thank you for the very important questions. Starting with the first one regarding the follow-up period. So that's definitely a limitation, and that's what we're trying right now to collect more data with further follow-up in order to account for that, because we know surgeries, the improvement's gonna last a long time. So we're definitely planning for that, and that's why we were waiting to get these results before publishing our manuscript. So that's definitely in process. In regards to the inflammatory markers that you mentioned, so this study is a retrospective study, but we definitely believe that we need to measure hormones, because we think this is very important. And we know that there's significant differences in between procedures in terms of that and the gut microbiome and bile acids, which we know that are also affecting this in cardiovascular improvement. So we think this should be studied, but unfortunately, because our retrospective study, we're not able to calculate and see the hormonal effect. I'm not sure if I'm missing one of your questions.
What is your plan to add social determinant of health, and how is going to be your determination what type of surgery based on BMI or cardiovascular?
Right. So, based on our study, we know that duodenal switch improves more cardiometabolic outcomes. So we think maybe if a patient presents to us with a higher cardiometabolic and cardiovascular risk, they might be, duodenal switch might be a better option to them if it's doable. So we think I think the criteria shouldn't be BMI by itself, but I think it's the cardiometabolic assessment of that patient and each patient alone that can help with deciding between surgeries, and it's a shared decision making between the patient and the surgeon to decide that. And the last question, sorry, can you repeat that?
I think you answered all of that.
Okay, perfect.
Thank you so much.
Next question. Very interesting study. In California, you can't do the biliopancreatic diversion because Blue Cross will not pay for it. I guess they determined the malabsorption part was just too costly. So if I read your data right, which I think is a very important study, then if you have to pick between sleeve and Roux-Y for someone who's high cardiovascular risk, you should pick Roux-Y. Would you agree with that?
I do agree with that. So
yeah, I think that's a really important thing to stress in your manuscript, because I think that I was struck that your data shows it actually increased the risk. The other question I have for you is 1 year follow-up is a minimum, great. But we all know that 1 year, these people are losing weight. The nadir is 18 months, and many are losing to 2 years and more. So the question is, did you actually look at those that you had longer than 1 year and to make some determinations of how really the long term matters?
Right. So that's exactly what we're doing right now. We're trying to collect data further, more than 1 year, to see, if this cardiometabolic difference and improvement, carries on with time. We strongly believe that it's going to carry on. So with that's definitely in process, and that's why we're waiting for the manuscript so we can collect this data. And you mentioned that the risk increases with sleeve. That's true, but we're also lacking a control group. We're lacking the group that did not undergo any surgery. So we strongly believe that if we had a control group, probably the risk would be increased further, maybe more than 1%. So even though we can see in the 10-year score, it did increase with sleeve, but we believe that in comparison to a control group, this is an improvement.
Thank you. I'd like to thank the discussants and the speakers, and thank everybody for attending this session.